Hello, today we are going to talk about platelets and how we test for platelets. Platelets are only about 20% the diameter of red cells. The normal platelet count is 150 to 350,000 per microliter of blood. Since platelets are so small, they make up just a tiny fraction of the blood volume. The principal function of platelets is to prevent bleeding. Platelets exist in two forms: the resting form, which is a flat plate-like structure, and then an activated form that has extensions that allow them to plug and seal broken blood vessels. When there is an injury to the vessel wall, platelets will attract and form a plug to stabilize the injury. To be able to do this, you must have an adequate number of platelets, and your platelets must be functioning normally. Platelets have a key role in primary hemostasis. If any of these phases don't function or perform optimally, abnormal bleeding may occur. Platelet transfusions may be indicated in the following populations: patients with a severe decrease in platelet number, stem cell or bone marrow transplant patients, or platelet transfusions can be used as a preventative treatment in hematology-oncology patients to prevent bleeding due to certain drugs and radiation therapy. The platelet dose varies according to the reason for transfusion and the size of the patient. One whole blood derived platelet concentrate per 10 kilograms or 1 unit of apheresis platelets is a standard dose. Some patients may need 2 to 3 of these per week, depending on why they're getting transfusions. ABO, as well as a few other RBC antigens, as well as HLA class I and human platelet antigens, are all found on platelets. AB antigen expression on platelets is highly variable. Some may be high expressors, while others, like A2, have virtually no A antigens on platelets. ABO type is often disregarded in transfusion of platelets, and this can lead to platelet refractoriness. Platelets have significant levels of HLA class I molecules on their surface. Most of the molecules are HLA class I heavy chains that have been cleaved from other cells and absorbed onto the platelets from the plasma. It has been estimated that 80,000 to 120,000 class I heavy chains are associated with each platelet. Those molecules can be recognized by HLA-specific alloantibodies. There are currently 35 human platelet antigens. Some are not only platelet-specific. Of the recognized HPAs, 12 occur in 6 serologically and genetically defined biallelic systems, where the A designates the higher frequency allele and the B is the lower frequency allele. You can see in this image that the HPA antigens are located on glycoproteins. What does platelet refractory mean? Platelet refractoriness is described as a less than expected increase in platelet count for multiple transfusions. This can be due to non-immune causes such as fever, bleeding, DIC, sepsis, certain drug reactions, or immune causes, which are ABO, HLA, or HPA antibodies, or it can be a combination of both. The most common cause of immune platelet refractoriness is due to HLA class I antibodies. This is estimated to be about 30 to 40% of immune-related refractoriness. The generation of antibodies against HLA antigens occur in about 7 to 55 of patients after platelet transfusion. These antibodies are usually detected within the first 2 weeks of exposure. To distinguish between immune and non-immune cause, you would take a 1-hour post-transfusion platelet count. For non-immune causes, the normal increment at 1 hour will return to baseline within 24 hours. For immune causes, there will be little or no increment within the 1 hour post-transfusion. Platelet refractory workups will include Class 1 HLA typing, HLA antibody screen, and an HLA antibody ID if the screen is positive, and HPA antibody testing if needed. While transfusions are necessary, supplement platelet requests with platelet cross-match platelets if HLA match cannot be found. Neonatal or fetal alloimmune thrombocytopenia is basically the HDFN of platelets. The mother's antibodies will attack the baby's platelets. Anti-HPA-1A is the most common perpetrator of this. Once the baby is born, the mother's antibodies will be in the newborn circulation for about 2 weeks. During this time, the baby's platelet levels may be dangerously low. HPA-1A negative platelets may be given until the antibodies clear. Sometimes the mother will donate their own platelets because HPA-1A negative platelets may be difficult to find. These platelets will need to be washed to remove the platelet antibodies. A baby presented with a critically low platelet count. A platelet screen was performed and the antibodies matched an HPA-1A antibody. This will be present in the baby and the mother's plasma. The mother was tested for HPA-1 and found to be HPA-1A negative. The HPA-1 antigens are codominant, and if only the HPA-1b allele is present, the phenotype will be HPA-1A negative. That was an introduction to platelets and platelet testing. Please let me know if you have any questions.